There are about 6 million Americans who have a diagnosis of heart failure and about 1 million Americans who have AV block. Block HF sought to answer the question, can biventricular pacing prevent progression of heart failure and its clinical and economic consequences in AV block? And now it's time to talk about the cost effectiveness of SAME. So I am with Dr. Philip B. Adamson, Oklahoma City, Director of the Heart Failure Program at Oklahoma Heart Hospital in Oklahoma City. Let's start with a reminder. We're talking about the Block HF trial. What were the original findings?
So the Block HF trial, as you mentioned, was a trial to address the specific situation of a patient who has structural heart disease and high-grade AV block, requiring high levels of ventricular rate support. Now, we had data before that trial that suggested that right ventricular apical pacing may actually be detrimental to those patients. So it was the DAVID trial. So we hypothesized that if we provided biventricular pacing for those patients, their outcomes would be better. We used a composite of 3 clinical endpoints of death, hospitalization or emergency visits, as well as an echo-based remodeling endpoint of left ventricular end-systolic volume index as a composite endpoint comparing patients with right ventricular apical pacing with BiV pacing. And we found a significant reduction in those clinical endpoints, an improvement with biventricular pacing compared to RV pacing alone. Everyone got a biventricular pacemaker in the trial, but they were randomly assigned to having an RV apical pacing or biventricular pacing. So we established then that in patients with structural heart disease who require ventricular rate support, biventricular pacing is the best way to provide that support.
So here at the AHA meeting, you're presenting all patient and subgroup analyses from the Block HF clinical trial. So first off, how did you do the analysis?
In a standard way, when cost effectiveness statistics are applied to a database, assessing the cost that is incurred for every quality adjusted life year saved. This trial examined, again, addition of one extra lead to a pacing system that the patient would already have an indication for. So the patient had an indication for a device. Would this device be cost effective when taking into consideration everything? And it's interesting, I've learned a lot with this, but it's interesting that as patients survive, they become more expensive. And the cost iterations for that survival have to be accounted for in this quality adjusted life year saved process. We found that the addition of the third lead or a biventricular system for these patients had a quality adjusted life year saved cost of about $38,000. The benchmark in the United States is a medical intervention, should be less than $50,000 for quality adjusted life year saved. And many people have suggested that that's too low. It should be higher than that. So we did a lot of different what-if scenarios in the analyses, and the statistical methods allow that kind of process. And we found that regardless of one's view on how often we revise left ventricular leads, how quickly batteries deplete, even in extreme scenarios, the cost of this intervention never exceeded $50,000 in any of our analyses. So around $38,000 for quality adjusted life year saved, with a significant improvement in clinical outcomes as well as survival.
And you also looked at some predefined subgroups. Specifically?
We did. We looked at the question of if you were, in this trial, you can imagine how difficult it might be to enroll the trial. If a patient comes in with a heart rate of 20 and needs a pacemaker, how do you go through the informed consent process for that patient? So it took a long time to enroll this trial. It took about 8 years to perform the trial and do the analyses. So we included patients who had no symptoms but structural heart disease, so class 1 through 3. We hypothesized that class 1 patients would live longer, and that was true, than class 3 patients, but that longer life would be associated with a higher cost because survival costs money. So we looked at class 1, 2, and 3. We looked at patients who had left ventricular dysfunction, more severe left ventricular dysfunction, but no CRT indication. We looked at a lot of different subgroups, and each of the subgroups also found that the cost increment was around $30,000 to $40,000 per quality adjusted life year saved.
So strong consistency of data.
It is, and it's interesting that it's consistent with cardiac resynchronization therapy. So remember that we weren't providing cardiac resynchronization therapy. We were providing biventricular pacing with a 3-lead system. Correct. When that 3-lead system is applied to a patient with heart failure and left bundle branch block, that's restoring synchrony in the left ventricle. So, and the cost for a quality adjusted life year say for that process is about the same as what we found with the Block HF data.
So Dr. Adamson, what's the final take-home message that you'd like people to take away from?
I think we've learned now that biventricular pacing is the appropriate way to provide ventricular rate support in people with structural heart disease that don't have a CRT indication. That this revolutionizes how we apply pacing technologies, and that the cost associated with that is well within what our society says is an effective therapy that's a cost-effective therapy.
So any other analyses coming out of Block HF?
Oh, we're looking at the remodeling over time, the echo-based data. That data set is in a final review in a journal, and hopefully that will be available for public domain soon. So we're looking at how patients responded both from right ventricular apical pacing to overall remodeling in the ventricle.
So congratulations. A good analysis and some more good information from the American Heart Association meeting. Please see our December issue of CardioSource World News, where I'm Executive Editor Rick McGuire.